Hello, my name is Rob, and I'm one of the plastics and reconstructive surgery registrars working in Victoria, Australia. And I'd like to thank the organisers for giving me the opportunity to present my group's research on the use of targeted steroid injection to augment the effects of collagenase in the treatment of Dupuytren disease. As we know, there have been multiple studies demonstrating the use of collagenase as a treatment for Dupuytren disease. However, there has been an issue of recurrence following this treatment. When looking at the data in vitro, there have been multiple studies demonstrating the utility of steroid use in cell models to stunt the growth of myofibroblasts, inhibiting the fibrotic process, and increasing the rate of apoptosis of these cells. When we look at clinical studies to elaborate on these, there's been demonstrated improvement in symptoms and reduction in nodule size, although the results were not durable, requiring further administration every few weeks to every few months. There was a study analyzing PNA as a treatment and steroid use, which showed promising results. However, by 48 months, there was no statistically significant difference. So the aim of our study was to assess, does the use of steroid injection post-collagenase treatment and manipulation increase the durability of the treatment effect as determined by the passive extension deficit? So we performed a single center cohort study between February 2016 to August 2018. We collected patient demographics such as age, height, weight, past medical history, and social history such as smoking and alcohol consumption. Proms were administered to the patients, both at Uram and Southampton, before and after the procedure, and baseline passive extension deficits were measured as well. In the outpatient clinic, local anesthetic nerve block was infiltrated, and from there we used collagenase off-label. That is, we used it with either 0.5 or 0.6 mils of diluent in small aliquots, evenly distributed across the number of joints treated by injections directly into the cords of interest. Afterwards, we brought the patients back 7 days after the procedure for manipulation, and this is based on data we previously published that demonstrated the same efficacy as waiting for 1 day. However, it allowed for patients more flexibility. We also only injected in those without relative contraindications, that is, patients without diabetes or who hadn't refused steroid injection. Looking at our results, there were 426 cords treated in 202 patients. Approximately half were treated at the MCP joint and less at the PIP joint. Of these patients, 188 had clear documentation of corticosteroid injection after manipulation, and of these, 173, that is 92% of patients, were administered corticosteroids. When looking at the baseline characteristics such as age, height, and weight, there was no statistically significant difference except for diabetic status. When looking at this table here comparing MCP and PIP joints, passive extension deficits, we can see that pre-treatment and at the 6-week mark, there is no statistically significant difference between these cohort of patients. However, by the time we move to 6 months treatment, there is a statistically significant difference with those injected with corticosteroids recording better passive extension deficits, in this case a median of 0 degrees, versus those without corticosteroid injection having a median passive extension deficit of 15 degrees. At the PIP joint, though, the baseline characteristics were a little different and statistically significantly different, with 59 degrees in the group without steroid injection versus 37 degrees in those with the steroid injection. However, as we go into 6 weeks, there is still a statistically significant difference, but by 6 months, this difference had disappeared. Now, going on to looking at the patient-reported outcome measures, we can see that in both groups prior to the treatment, there was no statistically significant difference for those who were and were not injected. Looking at the 6 weeks post-treatment, there is now a statistically significant difference, with patients without corticosteroid reporting higher PROM scores, favoring no treatment versus those who hadn't been treated. And much of this was attributed to pain. However, by 6 months, the difference was no longer statistically significant. And these results are similar to our other study published that analyzed skin tears, which demonstrated by 6 months, skin tears did not seem to bother patients based on the problems that were recorded. So, in conclusion, intralesional injection of corticosteroids into the disease cords seemed to increase the durability of the results at the MCP joint, but not the PIP joint. And we need further investigations over a longer period than 6 months to examine the durability results, given the lack of data in the literature and our study analyzing this phenomenon. Thank you.